July 11th, 2025. This is what I always say. This is This Week in Pharmacy. It's This Week in Pharmacy. This is TWIRx. My name is Todd Uri, founder of the Pharmacy Podcast Network. Excited about today's show. It is packed, so we have to get going. We have news to talk about in the industry, things happening. We want to review the major topic today, which is the One Big Beautiful Bill. If you haven't heard of it, you're obviously living under a cave or somewhere, but it's impacting healthcare. It's impacting the way we live as a nation. It's very controversial. It's not in place yet. It's not to really get its teeth per se until 2026. A lot can happen between now and then. There's a lot going on. You guys are stressed out. Pharmacy's stressed out, but you're doing such amazing things. We are getting ready for multiple conferences. We're going to be talking with Nicolle McClure, celebrating her 15th year in marketing for pharmacists and pharmacies, which we're excited about. And our special guest returning, Paul Liabenow. He's just amazing, and we cannot wait to share it with you on TWIRx coming up. This Week in Pharmacy, Ryan, you're back. It's great having you here in the studio again. You are in, I'm guessing, North Carolina. Boston.
Yeah, I know. You can't keep track of me.
So what's Boston like this week? Because it's been rainy, sunny.
It's been hot. Yeah, it's, living half the year in the Virgin Islands, we've gotten used to really hot weather. So it doesn't impact us as much as everybody else in Boston complaining about the weather. But, it's kind of like this. I grew up in Michigan, and we would, joke that, if it wasn't the weather that you wanted, just wait 5 minutes and it probably would be. But on the same token, everybody complained about the weather. It was either too cold or too hot, or it wasn't something of either. So, it is what it is. But yeah, I mean, it's been beautiful out. I'm glad to be here with you today. Friday, beautiful day. Excited about our topic.
Yeah, it's an important one. And we're absolutely going to jump into the One Big Beautiful Bill. I can't stand the name. It's just didn't sit right with me as a piece of legislation. Didn't understand. It seemed a little bit too fanfare for me. I'm a little bit more conservative in the way I like to name things, but that's someone that's called his show TWIRx. So maybe I'm a hypocrite. I don't know, but we're gonna get into TWIRx news right now. There's a lot going on in our nation. Our nation and our profession is transforming, and it's hurting. Here out of Pittsburgh, Pennsylvania, the headline from WTAE Channel 4 is Giant Eagle promises faster pharmacy service after new customer backups. And they're sucking up a lot of what happened with Rite Aid and the collapse of Rite Aid. Rite Aid was headquartered out of the Harrisburg area, and they've had a special relationship with the Pennsylvania Pharmacists Association. Bankruptcy finally took hold. They're going to be, Giant Eagle's been making up for 78 of the Rite Aid locations. And this just goes back to our discussions before, Ryan, about how when you close community pharmacies, it's a huge domino impact to public health. And it's kind of scary. It's because people don't know. I mean, they're used to going to their pharmacy, whether that be an independent or a retail chain. Regardless, it's access to some minimal level of care. You and I were just talking before we started recording about people that don't even go to the doctors as they should be. So, yeah, it's part of what's happening in our nation, and in the impact of current policy and which we'll talk about when we get into One Big Beautiful Bill. But What about in Boston area? I know there's Rite Aids up there. Are you seeing anything in your local community that's being impacted by these pharmacy deserts?
Yeah, I mean, I think that Boston's pretty solid. There's definitely still an independent pharmacy presence in Boston metropolitan. But you still have, I mean, CVS and Walgreens in the city is really dominant. They're on every single corner. If you want to walk into a pharmacy, there is no issue if you live in the city. I would imagine that once you get out toward Western Massachusetts, then, it's a little rougher. I think that the population is just different in Western Massachusetts. But what I would say is that within a 25-mile radius of city center, there's plenty of access. Just not seeing it. I mean, and I don't think that New York City's seeing it either. Los Angeles isn't seeing it. Some of the big metropolitans are not necessarily seeing a desert because CVS and Walgreens have just got such a dominance in those areas.
Yeah, the news continues out of Virginia. 13 News Now reports just this week report finds 51 communities in Virginia now meet a pharmacy desert criteria. And it goes on to say that Virginia lawmakers learn about decreasing pharmacy access, with researchers finding 51 areas labeled pharmacy deserts as pharmacies keep closing. So it's in Northeast, Midwest, the West Coast. Everyone is being impacted by the closing of pharmacies and the bankruptcy of Rite Aid and the closing of independent pharmacies. Sometimes it's the only, once again, access for. Um, and then in good news, before we get into our topic today, the Community Pharmacy Enhanced Services Network, known as CPESN, honors 32 community-based pharmacies. And this is sponsored by the Compliant Pharmacy Alliance, the CPA, who's going to be coming out with a new series on the Pharmacy Podcast Network. And a shout out to CPSN for really helping pharmacists and pharmacies throughout their communities understand how clinical services go far beyond just dispensing, especially with some of those chronic disease states. And Dr. Troy Tragstad's done an amazing job helping to educate and empower our community pharmacies through CPESN. So shout out to CPSN for your work. Continue to do what you do. We hope to run into you in some of these conferences. But one of the aspects that I wanted to ask of your insights, Ryan, is mental health. And I'm wondering if CPESN has a very specific segment of what they do to empowering and building programs around mental health services.
Yeah, that's a great question. I am in the desert as it relates to whether or not they have a mental health and addiction treatment program specifically. I know that in pharmacy in general, behavioral health has become more talked about, and I think that our organization Mango Health has done a pretty good job of educating the community about what it looks like to integrate pharmacy into that therapeutic category. So that's a good question. I think that we should ask them.
I think we should too. I'm going to send out a message out to my connections at CPSN and ask them to connect with you and connect with what Mango Health has done on a national scale. Just for the listener's sake, if they haven't heard previous interviews that you participated on, let us know, as someone who came from epidemiology, how you evolved and helped to build out Mango, and how that's a specialty pharmacy that's digging into mental health, digging into addiction, and there's a mission behind this. But give us just a little overview of Mango.
Yeah, I mean, so how did I transition from epidemiology into the pharmaceutical industry? That's a pretty big arc, but short is that I've always worked in population health, identifying and studying and researching populations, disease states, and therapeutic categories within those patient populations. And so it was a really interesting opportunity for me early on to be able to work with managed care organizations to be able to identify opportunity for programming And so that got me into managed care, and that managed care got me into, because my specialty is in pharmaceutical epidemiology. So, we are interested in how drugs treat disease, right? It's really, really clear and specific. And so that was a good fit for what ultimately ended up being a health insurance industry career early on. And I got connected with a pharmacy benefit manager that said that they didn't take rebates, right? And that pharma did not control their formulary. And it was very exciting to me. So I became one of their executives. I was their executive for 7 years, and decided that I could do it differently and maybe a little bit better under different circumstances. And so I left and started a company called Health Clarity that ultimately grew into one of the largest specialty pharmacy management companies in the country, working with over 36 health systems in a little over 40 states. We had 350 administrative employees and hundreds and hundreds and hundreds of clinicians across the country. When I sold that organization in the middle of the pandemic, primarily because we were attractive, we had a really huge infectious disease infrastructure. I decided that I would take a step back and start to ask the question about what would be the next bastion of opportunity for us in pharmacy. And I continued to ask. I'm a person in recovery myself. And so I started asking mental health and addiction treatment organizations, why don't you have on-site pharmacy? It would make perfect sense for you to integrate pharmacology into your practice. They said, we don't know. It's probably something that we'll never do because we're not going to do it on our own. I said, perfect. This is what we're going to do. So we established Mango Health as a micro pharmacy behavioral health solution. So simply put, we come on site to a behavioral health organization. We build a 600 to 800 square foot pharmacy. We completely staff it. The cool part is what sets us apart is we don't own the real estate. We don't own the patient. We don't own the data, right? So that is completely the facility's owner. The facility owns every aspect of the program. We just operate it. And that's important because that creates integrity in the care continuum. And so we're having some great success. It was slow going to start, and now we have just exploded really the last year, and we're excited about what we're doing.
That's awesome. And congratulations. I like the fact that you integrate pharmacists into this entire business model and how important they are within mental health. And sometimes the only healthcare provider that's on a consistent basis, seeing those people over and over again. And I've talked about Mango Health to a lot of our buying groups to see if there isn't a connection. I think there's some future opportunities coming from a lot of that. So excited about that. Really pleased that you were able to share and also come back, and a shout out to our pharmacists who are interested in behavioral health more. By the way, just go to mangohc.com. Once again, that's mangohc.com. And if you do have interest in working with Mango Health or behavioral health, go to the contact section and fill out information, ask questions. We are, I guess it's an inflection point per se with regards to what our nation's going through. And today's subject is a closer look at the one big, beautiful bill. And like I said at the beginning of the show, I can't stand the name. It's just it's almost like parody. And I'm just like, come on, like this didn't come from the Babylon Bee. This is actual legislation. But regardless, today's discussion, which we're featuring Ryan and your insights, you have a very wide stance and information and research that you've done, because some of these things impact your business and what you're doing and the realm of pharmacy care. But just right from the beginning, let's get into it. Let's get your insights into what is now been signed, I guess, on July 4th of this year, just a couple days ago, the one big beautiful bill. Ryan.
Yeah, so I think that the first and foremost, we have to rename it the Big Ugly Bill. That's my opinion. That shows a lot of my cards, I suppose, by calling it that. But the reality is that there's a lot of I have a difficult time digesting what this means for healthcare in general, because it means so many things. Because this isn't just a dry budget adjustment of partisan compromise, right? It's not. We didn't just show up and say, hey, you know what? There's just a lot of fraud, waste, and abuse, and we need to take it out, right? So if we're talking about healthcare only in this bill, that's the only thing that we're going to talk about today, is that it's really a calculated assault at the most vulnerable people in this country, and it's disguised as fiscal responsibility, right? I have to remember, like for me, being an epidemiologist, our really focus, is looking at public health from a lens of those that do not have access, right? So the majority of my career has been working with vulnerable and marginalized communities. So I'm going to see a lot of this through that lens. Now, I acknowledge, right, that the listenership doesn't have the same politics that I do, that everyone that's listening doesn't have the same politics that I do.
Yep.
But what I think is important to recognize is that when it comes to Medicaid is really important for the pharmacy industry, because that is a significant segment of reimbursement for the pharmacy industry. And when you're cutting $1 trillion of Medicaid over the course of the next 10 years, and again, I also acknowledge that a lot can happen in a day, and much less over a year. As it relates to how Medicaid is cut. So maybe, miracles of miracles, something changes and I end up being wrong. I hope I am. But the reality is that from, putting us in a position where we're going to struggle with preventable deaths, where we're going to ultimately see rural hospitals shutter, where we're going to see just a slew of cruel work requirements, right? I mean, people don't recognize, for instance, so this is the conversation that happens that, there's two things, there's a bunch of people that don't work, that, are just laying around, lazy, taking advantage of the system. So number one, that's not true. 83% of all individuals on Medicaid are working and under-resourced. The rest are children and disabled, right? So you're talking about a minuscule percentage of people that are quote unquote taking advantage of the system, right? And this includes SNAP benefits as well, right? People are not taking advantage of SNAP benefits in nauseum, right? It's just simply not happening. But what we will see from a health policy perspective is we're going to see this lead to 51,000 preventable deaths per year. We're going to see job losses in healthcare of about 500,000. It's going to really limit our ability to be able to service that vulnerable and marginalized population. It's going to have like I said, it's going to have a devastating impact on rural hospitals, rural areas where Medicaid is a lifeline, or we all know it's disproportionately affected already, right? And we're already seeing clinics respond to this bill by shutting their doors because they're like, this is the last straw for us. There's just no way for us to continue on. Another real concerning piece of this bill is the cuts to children's health, right? Children make up nearly 40% of Medicaid enrollees, and these cuts actually jeopardize access to pediatric care, vaccines, developmental screenings for millions of kids, right? So again, I ask, where is the compassion in that? Let's just simply say that there are able-bodied adults that are taking advantage of the system. Fine, remove them from the system, ask them to at least work or seek work, right, to be on Medicaid. I get it. I don't have a problem with that, but that's not what we're attacking. It just isn't, because that's such a small amount. It doesn't even begin to scratch the surface of what they're trying to come. And then when it's all said and done, the question is why are we cutting all of this? Mm-hmm. Where's the money going?
Yeah,
it's going to ICE. It's going to people that make over $1 million a year. Look, I'm going to get a tax cut. I don't need that tax cut. Don't need it. Don't want it. Don't care about it. Doesn't matter to me, right? That's just the reality. And so I think that, as we kind of navigate a lot of these things, we look at what this really means, which is a cut to the expansion of Medicaid, right? And where we saw, excuse me, when we saw a decrease of about 10 million, or an increase in about 10 million in going to see an increase of about 5 to 6 million in unemployment. And I don't even know what to say to that, other than it doesn't make any sense, because it doesn't improve the quality of life of an individual that would put them in a position to be healthy, that would put them in a position to work, to be a contributor of society, to be able to take care of their family, to be able to put food on the table. Public health is life, right? That's what I tell people. It's not just I have a card and I get to walk into a doctor's office and pay a $10 copay. It's everything else that's wrapped up in the reality of whether or not I'm healthy, right? And what that impacts, which is everything. The way in which I parent my children, the way in which I show up in the world, the way in which I show up to work, the way in which I communicate with people, the way in which I, the opinions that I have, right? And to top it all off, this is not blue states, because blue states will bankrupt themselves funding state level Medicaid to keep these people insured. Who's going to be affected the most is the right-wing conservative base in red states. And everybody knows that. Like, they just don't want to have that they don't truly want to have the conversation that the constituents that voted for this are going to be the ones that are hurt the most, right? Because blue states subsidize red states across the board, right? Because they just pay more taxes, right? Well, you can say, oh, well, that's why blue states are bad, because they pay more taxes. Well, that may be the case, but it still doesn't. The reality is, Louisiana, for instance, or Arkansas, for instance, where 3 or 4 to 1 of the dollars sent in that actually come back to those states in federal aid, right? So it doesn't really balance itself out, right? And so if we look at, the overlying issue is that, do we care about disproportionate harm to marginalized communities? Black, Latino, Indigenous, disabled communities are more likely to rely on Medicaid. It's just the reality. And that's not a good or a bad thing. That's just a fact. That's just a statistic. And these cuts compound racial and economic disparities, further entrenching inequality in the U.S. healthcare system. And we've been working so hard, right? Epidemiologists and public health practitioners and physicians and NPs and researchers, we've been working really, really hard so that the concentration isn't, oh, well, we'll just make sure that rich white people have healthcare, right? We have to balance this out with the fact that there is a huge disenfranchised part of society that needs to be taken care of, regardless of what a particular political group wants. And so I implore the audience that, search your soul, search your heart on this. There are some things in the bill that are livable, that can be tolerated. But when it comes to healthcare is under attack in America more than it ever has been. And if you think that NADAC pricing plus a dispensing fee now is bad, what would happen if dispensing fees went away?
Mm-hmm. Yep.
It's called you get to work for free.
Yep.
And this is what we're looking at today.
Yep. Yeah,
that's my soapbox, I suppose, for today, Todd.
No, that's my fear. The fear is that it's going to cause additional harm to the cycle that we see. Let's say I have a 3-year-old child. They start having a cough. It really doesn't sound that bad. Because it doesn't sound that bad, I give them some over-the-counter cough suppressant. It's still an issue. A couple days later, there's a fever. Suddenly, it's 103 degrees. I'm very scared. And guess where I go? To the emergency room. And like, instead of going to my clinic that was covered based on programs, now I've exacerbated this whole situation from care, accessibility, pricing, cost, because I went to the emergency room. So life and the combination of life and economics is like pouring a bucket of water down a hill. That water will go wherever it wants to go, regardless of policy, regardless of laws, regardless of funding. That water goes downhill. It finds the nicks, it finds the crannies, it finds everything. And that's the reality of humanity, and reality of, hey, if I am needing something and I didn't have it before, to make sure that my child had a dentist appointment and that they're seeing the dentist twice a year, as they should, for cleanings, and now there's an issue. It's just more cost because it's not being handled on a month to month or twice a year, or whatever the checkups are. And I think that's definitely a red flag to me, is, hey, we have to do the basics and take small steps to ensure that we have some type of coverage happening for those people that don't really have anything, because otherwise they're just going to go to the emergency room when it blows up, and by that time it might be too late.
Yeah, no, this can go a million different directions. I wish that I could touch on, again, I'm just throwing out some stuff that's in the bill so that people can start to do their own homework on it. I think that it's important that you be educated and don't just say, oh, well, Ryan said X, Y, and Z, so therefore it's not that simple. It is actually it's actually very complex once it rolls itself out. And yes, Todd, you were right in saying, we've got some time, right, until we start to feel the heat. But what do we do until then to prepare for it, right? I mean, we, at Mango Health are, by the end of the year, we'll have a Medicaid population of about 35,000, right? That's direct patient interaction, not just, like adjudicating a claim or something. I'm talking about a Mango Health licensed pharmacist having an interaction with a human being. Mm-hmm. And so what does that mean for that segment of our business? Because I can tell you this, we're not going to stop doing that. Like, that is like my life, right? Like, the reason why I have any blessing in my life whatsoever is because I do that. Otherwise, I have nothing, right? In my opinion, like, that's my identity, right? Is doing that type of work, because it's easy to do. Like, here's the reality. The reality is that I will put this out here as well. Contact me if you are a business owner in pharmacy and are struggling to make ends meet, because there are ways to innovate. There are ways to franchise this thing. There are ways to become specialists, to do facility work, to do infusion programs, to do 340B contract pharmacy. There are a slew of things that can keep you in business, right? And help you make more money than you've ever made before, as a result of being innovative and blocking and tackling and making changes to your business plan. I am wide open as it relates to having those conversations, because at the end of the day, I come from an independent pharmacy family, right? Yeah. Robert Tozer Allen, founder of the apothecary shops, right? Thousands of pharmacies, right? What was essentially a Rite Aid Midwest was what my grandfather did. And so, like, I grew up with it, right? And independent pharmacy was different, right? It was just, it seemed easy because my grandpa never complained about reimbursements and managed care. And by the time it became PBMs became a real issue, Rite Aid was already buying his practice, right? So there's just opportunity out there. And one of the huge ways to open up doors is to serve vulnerable and marginalized communities, right? And if you have the stomach for it, and you have the propensity for it, and you have the desire for it, you can be quite successful taking care of under-resourced communities. The sky is really the limit, because that's where the innovation needs to happen, right? Because, if you've got a little bit in your bank account, right, and you look a certain way, you will always get healthcare and you will always be okay. But that's not the majority of the country that needs our help. So I implore you to give that some thought.
Yep. Thank you for that. If you are curious, if you're listening, if you're driving, if you're jogging, you're not looking at your screen, if you're watching us on YouTube, that's great. You'll see this. but at congress.gov, the detail of HR1 is in great detail. It's very long. It gives you actions, breakdowns. It gives you the amendments. It gives you co-sponsor information, related bills. Jump into this as a healthcare provider and just understand. It's to me. I always look for the summaries, the quick summaries, because we're always doing work, we're running. But I did take time to look through this, but read through it, understand it a little bit, and then reach out to your own legislators, reach out to your local Congress people, your state senators, invite them to your pharmacy, invite them to see your hospital pharmacy or your specialty pharmacy or your community pharmacy, because if they understand the services that you're providing, it's going to make them think back to this bill. And it's also going to make them think of their own state funding and how that money is being spent. Because if providers don't have a voice at the table, now you're just pushed aside, and then the administrators are doing whatever they want. And I hate that. So pharmacists listening, take time to just reach out to one of your legislators, just say hello, introduce yourself, let them know what you do. And then if you have a community pharmacy, if you have, I'm even shouting out to Giant Eagle or to Independent or to regional. If you're a regional director at CVS, reach out to your legislators and say, hey, come take a tour at one of our pharmacies and really go behind the counter and look what we're doing and understand what a dose packaging does for adherence and watch our abilities to do immunizations as we do, because the healthcare outlets, the touch to the people, like you said, Ryan, the reality is the pharmacy is in most cases the only healthcare provider that many people have access to. And when we're seeing those close and we're seeing pharmacy deserts and we're seeing an expansion, once again, it's all going to bubble up to an explosion because people are going to go into the emergency rooms because they're going to be desperate. And like I said, by that point, it may be too late. So
Right.
I don't want to be all doom and gloom on today's TWIRx, but it's things to think about, and it's reality, and we're all adults and we have to think about these things. But this has been a great conversation. You're always bringing enlightenment to us, Ryan, and we appreciate you.
Yeah, thanks for having me. It's always fun.
All right. When we come back, we are going to be talking with Nicolle McClure, and we're going to also be talking about the conference run. This is going to be a crazy rest of 2025 because there are a lot of conferences going on, important conferences going on. Stay tuned. We will be right back.
This episode is sponsored by Independent Pharmacy Cooperative, widely known as IPC. Established in 1983, IPC is the nation's largest group purchasing organization owned by independent pharmacy. With a mission of maximizing the success of community pharmacists, IPC works to provide members with access to effective programs and services designed to enhance profitability for independent pharmacy. Read more about our mission by checking out our website at ipcrx.com. That's ipcrx.com.
Hey, and we're back on This Week in Pharmacy, and I'm excited about what's happening. This is a record-breaking year for the Pharmacy Podcast Network. We will be attending all three of the shows for the wholesalers, and that is starting with the RBC. Adam Robinson, Dr. Adam Robinson, who is a pharmacy owner at Save Right in Kentucky, will be covering the RBC event in Denver. He's actually there right now. It's going on as we speak, and we're excited that we're getting to cover that. RBC does an amazing job. In my opinion, RBC Retail Business Conference from Cardinal is the best conference for families. So if you're a pharmacy owner and you have a family, bringing your kids there, your spouse there, getting them involved. They have a kids camp that still no one has ever touched, the kids camp that RBC puts on. And I've been there several times. All right, we are headed, and we're here now on Friday, July 11th. We are at the Idea Share, McKesson Idea Share in Nashville. happening as we speak. It's great to be part of this. Our partner IPC is there, and we're embedded inside their booth, and we'll be covering the event. If you have something to share, if you're hearing TWIRx today and you are in Nashville and you're at the Idea Share, please come by and see us at the IPC booth, and we're so excited to be part of it. Then Thought Spot, like I said, 3 for 3. Pharmacy Podcast Network is press coverage for Thought Spot. We're going to be partnered up with Outcomes, which is a medication therapy management review system. We're so excited to be sponsored by Outcomes. And the conference world and conference from this point forward in pharmacy is just amazing. There's so much going on. I love going to conferences and talking with you, pharmacy owners, people in pharmacy. And one of those people in pharmacy that I've been close to over the years has been Nicolle McClure, who's a fellow marketer, and she helps with business development for community pharmacies. There's 2 sides of Nicolle's world. There's the original side that's celebrating a 15-year anniversary, which is GRx Marketing. And then there's Finch Marketing that really focuses on the business of pharmacy and those businesses that are serving health system and specialty and community pharmacy and long-term care. I want you to listen to this interview with Nicolle. Reach out to her if you have any questions, and we're excited to welcome Nicolle McClure. Hey, welcome back to This Week in Pharmacy. One of my favorite topics, this comes up a lot. I think of what pharmacists go through and getting to where you are in your education, becoming a pharmacist, licensing. I also think of your specialty, whether you're a community pharmacy pharmacist, if you're a community pharmacy owner, long-term care specialty. Compounding is expanding. Infusion centers, my goodness, a way to make money, any way to make additional funds of things that your patient needs that you can make money off of. And long-term care at home has come up. You hear us talking about long-term care at home pharmacy constantly. And the reason why that's so important is because there's a demand for it. There's a demand for, hey, I don't want to go to a nursing home. I want to stay at my home, but I need someone to look over medication management, remote patient monitoring, whatever that is. And then we're talking about, well, how do we get that messaging out? Well, that comes back to marketing. It's important to understand marketing specifically for pharmacy care, but let's break that down. Marketing properly for community pharmacy in comparison to specialty, in comparison to long-term care. There's a podcast that we have on the network, and it's a very important part of the network because it's a great way to dial into exactly what we just talked about. This is Marketing Vitals on the Pulse of Healthcare. And this is commanded and designed, developed by the GRx Marketing team. And we're very lucky to have them. I want to welcome to the show Nicolle McClure with GRx Marketing, founder of GRx Marketing, the biggest cheese on the stick within GRx Marketing. Welcome to This Week in Pharmacy.
Hey, Todd. Thank you for having me.
You're going to become, I don't know if you watch Saturday Night Live, but they'll have the gold jackets that the guests or the host will wear. And if you host more than like 5 times, you get one of the gold jackets. I think you've been on TWIRx now. Might be, we have to get you like a TWIRx.
I need a gold jacket or like a gold necklace or something.
Exactly. Something that says TWIRx on it or something like that. How are you?
I'm good. How are you?
I'm doing good. I want to say congratulations. You're celebrating a special anniversary this year. It's pretty monumental. I've been around long enough, I'm getting old, but I've been long enough to see you launch GRx Marketing from the very beginning. And this is your 15th year anniversary. So congratulations.
Yeah, thank you. We're excited. So it's hard to believe it's been 15 years, but it's been a fun ride.
So GRx Marketing, just in case our listeners are listening in, they're not quite sure what that means. Talk to us. What is GRx Marketing? What have you done? What have you built? And now, which I'm excited to talk about, is getting into the granular, getting into specialty or community or long-term care at home. So talk to us about GRx Marketing a little bit.
Yeah, for sure. So we are a full service marketing company that works exclusively with independent pharmacies across the United States. My background is working with in pharmacy since 2004, so just over 20 years. So through just past experience on opportunity to offer marketing services to pharmacies, because a lot of them struggle with what to do for marketing, how to do it, and then the execution side, right? Like, you guys are so busy throughout the day. You've got a million things going on, and oftentimes marketing gets put on the back burner, which doesn't always work when you're trying to grow your business. So with GRx Marketing, we offer a lot of services to help with digital aspects, so social media management, website design, digital ads, that sort of thing. But also on the strategic side, so putting together a marketing plan for the pharmacy, and it's based on that individual's goals and needs to grow in their local community. Also helping with local outreach. So if they're trying to reach doctors to talk about their services, or maybe community members, they want to promote that they can do flu clinics on site. So they want to reach out to local businesses, kind of all of that to help market the pharmacy. And I would say what has helped us survive and thrive for 15 years is our uniqueness, in the sense that it's very customized approach. It's not one size fits all, but also we try to implement as much as we can for the client. So it's not, here's all these ideas, now you go do them. We actually take care of a lot of it for the client, whether that's, posting to social media, actually reaching out on behalf to their prescribers via mail or email, that sort of thing. So really just taking that legwork off their plate.
That's great. I watched it. I watched you change. I've watched you add your team. Your team's really expanded, and then your specialties have expanded. Now you're dialing into specialty. You're dialing into long-term care more so, and you're going to that traditional retail community pharmacy owner operation, and you're saying, what's the next sector of pharmacy that you're dialing into? Let's make sure that we're messaging and communicating with the community to let them know that you're even doing what you're doing. And that's my next question for you. How are you differentiating and helping a community pharmacy dial from messaging their, communicating marketing with their community about, hey, I'm now servicing long-term care at home patients, so that if I have a mother, if I have a father or a loved one, I didn't know that was available. It's something that our community pharmacies have been doing forever, and they've not gotten paid for it. Now there's certain ways to structure it in certain compliancy through CMS and for paperwork in your state, that if you do things the right way, you can make a lot more money. So talk to us about that a little bit.
Yeah, for sure. So, as the industry has evolved, we are seeing a shift with our clients where they are getting into more of these type services. So it's not just, hey, we can fill your prescription or we offer delivery, that sort of thing. It is really taking on these different verticals. So again, it's a lot of consulting conversations with our clients, but also recognizing that if you are starting in specialty, for example, that marketing is going to be different. That's going to be very prescriber heavy, or maybe trying to reach out to insurance companies, things like that, versus traditional retail is more patient focused. And then again, with long-term care at home, making sure that we're notifying that targeted caregiver group that, hey, we have a solution for your parents to stay in their homes longer. Or maybe it's your older patients, notifying them via a good old-fashioned letter from the pharmacy still does wonders, but tagging on, maybe a text message or an email message to follow up with that, letting them know about what their pharmacy is now offering. Because I think that's honestly the biggest detriment we see with pharmacies is they're doing all these great things, but they're just not letting people know about it. And so a lot of times the patients don't know that they've started this long-term care home or specialty pharmacy or that sort of thing. So that's where we can come in. And clients love that we know the industry. They don't have to explain to us the different verticals or even what a PBM is, we can sympathize with kind of what's going on and are very aware. So we're very mindful of that when putting marketing strategies together.
Yeah, holy cow. It takes a long time to really understand context and how to describe things to patients in your community in a way with graphics or a PDF or some email or some social media engagement to educate, constantly educating. Education in itself can be marketing. It doesn't have to be one or the other. It can be a two-in-one deal, and then rinse and repeat, but keeping it up. So that would make me tired just thinking about. I'm very guilty of this. I don't market the services of the Pharmacy Podcast Network alone because I'm concentrating on my client. I'm not concentrating on us as a publication per se. And it would help my clients and future clients to know what actually we do to help them use podcasting to get their messaging out. Well, that's exactly what you're doing. You're saying to this community pharmacy group, you've saturated in marketing for community pharmacies specifically for over 20 years now, and 15 years through GRx Marketing. You're now starting to split the hairs of different marketing campaigns that will fit a specific pharmacy, and then customize and rinse and repeat so that it's something monthly happening, whether that's a blog or whether that's email messaging. But talk about some of the services that you're actually helping our independent community pharmacies implement and then stay up with.
Yeah, for sure. And just to, touch on your comment about consistency, I think that's one of the hardest things, because sometimes, when we're talking to pharmacies, we hear, oh, we'll have somebody in-house do it, or, we can do it ourselves. And it's hard to do it day in and day out or week in, week out. So that's where, it takes probably 8 to 13 times for people to see a consistent message or a message consistently before they even think of taking action. So you've got to really kind of hit them over the head with that consistent messaging. You can't change it every week, every month, that sort of thing. You really want to dial into what are your unique services. So as far as our services go, again, it's customized to what the pharmacy owner is looking for. And again, it's, if you're in specialty, we're going to recommend different services. So that more prescriber focused, where we can reach out to prescribers in your area. We can also really get granular and target those that are prescribing certain medications or by disease state. Maybe they're in a hospital setting versus a clinic, that sort of thing. So we can get very narrow on who we reach, and that prescriber outreach can work for anybody. But we found it especially effective for specialty because they are so much more focused on certain disease states, types of drugs, things like that. Sorry?
I said, I love it. I love it.
Okay. I would say a secondary, service with the email marketing. I think sometimes that's a forgotten thing on the patient side. It's a great way to remind patients of your services. I mean, think about all the patients that maybe you don't see on a monthly basis that just come in 2 to 3 times a year. Well, their needs maybe have changed in the last 6 months that you've seen them. So it's important to keep up on letting people know what you're offering. And then again, that email type marketing can be used to target prescribers, manufacturers, any sort of email list that the pharmacy has. We can target that messaging through email as well. And the great thing with that targeted, geofencing, digital marketing, and email is we can show the data that says, how many people open the email or how many people receive the ad, which I know pharmacists love because it's data as opposed to some more of the, gray marketing that is it effective? Is it doing anything for my pharmacy? So those are just a few of the services that I think bring a lot of value.
All right. Is there anything that you want to preface? Because we're going to have you back on a continuing basis, kind of dialing into very specific campaigns, strategies, maybe something that's changing in the market, as well as even compliancy, where maybe there's a way to market something better than what we knew. And the FDA came out with some new stipulation on Ozempic or something or whatever it is, but you have to understand those things. But can you give us any hints to what's coming?
Well, we are working on a few things, new services, not quite ready to say anything on that yet, but be sure to check our social media for more information. We are also working on finalizing or launching a partnership with you, Todd, on the Pharmacy Podcast Network. So excited to roll that out. So definitely be looking for more information on that as well.
And like I said at the beginning of the interview, you're a great gong of information on marketing in general, which is Marketing Vitals on the Pulse of Healthcare. And you can find that on any of your podcast players. I enjoy this podcast, Nicolle, because it even gives me little tidbits of information that I need to remember about marketing. So can tell our listeners a little bit about this show.
Yeah, so Marketing Vitals, it's ran by myself and my VP, Kelly Bailey, and it's giving tidbits on certain areas of marketing. So whether that's digital, it's a partnership with some of our partners. So talking with long-term care at home about initiatives that they're doing and how we're working together. So it's just a great way to tune in and pick up little tidbits, tips for helping grow your pharmacy. So we push one out every month. So make sure to stay tuned in.
Absolutely. We enjoy Kelly's viewpoints and digging into different topics. There is a podcast that was specifically on long-term care at home with Paul Shelton. It was an excellent episode that came out on June 4th of 2025. So if you go to the show page, you'll be able to look that up. But I think that long-term care at home is an interesting and very strategic play for all independent community pharmacies. If you're not fully implemented and you really want to understand how to launch this as a program and getting information out to your community, please reach out to the GRx Marketing team. Let them know that you heard us talking about it. And once again, grxmarketing.com. That's grxmarketing.com. Do you know, I've known you for how long? I can't even remember. It's definitely been a long time. I've never asked this question, so I'm asking it now, and then I'll remember. I have to remember the answer. GRx, what does that stand for?
So it comes from the previous company that I used to work for before I bought the business, is GRx Holdings. It was named after the previous owner. So GRx Marketing honestly just kind of started as a side hustle for that company. So I was like, oh, GRx Marketing. Little did I know it would turn into what it is today. But because the name is established in the industry, I've decided to keep it GRx Marketing. So yeah, that's where it comes from and what it'll stay. So
it stands for Great Pharmacy Marketing.
Yes.
That's just like, I always ask for that, like CVS, like I had no idea it was Consumer Value Services or something. And now they look back, or companies will look back of what their name is and what it became. And I'm in the vote of keeping it because I think it builds legacy and builds credibility as you move forward. So we're excited to have you being a bigger part of the PPN as well, and giving our listeners insights to latest marketing trends, especially when we get into the weeds with specialty and with expansion of long-term care at home and just specifics. But I'm excited to have you guys be a bigger part of this. And I think we'll be working together at several upcoming conferences in the fall of 2025 too.
Yeah, for sure. I'm excited.
All right. We will talk to you soon, Nicolle. Thank you so much.
Thank you, Todd. Have a good day.
You too.